So yes, hello, I'm Alastair Bishop. I work in NHS Greater Glasgow Clyde, as Aaron said, and I'm just going to spend a wee bit of time and bring you up to speed with our progress over the last year or so, implementing and rolling out the Orion Medicines Reconciliation and Immediate Discharge Letter functions. I'll cover a few things. I'll start just reminding everyone what problems we actually set out to solve with this project. I'll describe where we've got to so far, the approach we used to get there, and then I'll talk a bit about some of the lessons we've learned over the last year, some of the things that worked well, and also some things that we'd do differently, I think, in the future. And then I'll finish up just by summarising what the next steps look like for us. So a little bit of background before I get into that. I work in a NHS board, which is kind of Scotland's equivalent of a trust. It's in West Central Scotland. It's the largest health board or trust in the UK. We serve just over 1 million people directly, and we have a large number of regional and national services too. We have about 38,000 staff and 35 hospitals of various sizes. The project scope, so the scope to which we're rolling out the Orion system, in total is about 350 wards or 6,000 beds. We think about 10,000 people will use the system directly. And the board has about 400,000 admissions and discharges every year and around 9 million individual dispensing events. So that will give you some feel for the sort of scope of the project. So as one of the speakers said earlier today, I think it's very important to start any piece of work with trying to get clarity on what problems you're actually trying to solve. For us, we're really focusing on the fact that medicines information gets written down or typed into systems in hospital very often, very frequently while a patient's in, and that manual transcription wastes clinical time, and it also introduces the risk of mistakes being made. So the core aim of this piece of work is to reduce the need for manual transcription of medicines information. There's lots of other drivers though, lots of other reasons why we want to do this. We want to improve adherence to or uptake of that medicines reconciliation process at admission, and also the quality of that process. We want to speed up the discharge process and make sure patients are getting home as quickly as possible with the correct medications. We also want to release a bit of clinical time that's currently spent typing stuff in or writing stuff down to allow some of our junior doctors to think about the medicines decisions they're making rather than just focus on getting everything onto the system as quickly as possible. And finally, we think there's real opportunities to improve the quality of information that ends up on the immediate discharge letter, the summary document that the hospital sends out to the GP. There's a few things worth mentioning that we're lucky about in Scotland, and these have helped us with this project. We do have a single national patient identifier, which is more or less universally used, and that helps a lot with joining up across systems, clearly. We also have a single national system that is a repository of all the GP medicines information from all the GP practices in Scotland. So again, that helps simplify the integration part of this challenge. And there's also a number of UK and international data standards that we've adopted as part of this project, which again have helped us join things together, specifically DM&D for medicines and SNOMED CT more broadly for diagnosis recording. So our previous process before this project looked a bit like this. We had the GP medicines in the individual GP systems that would regularly feed into the national ECS, Emergency Care Summary. When a patient was admitted to hospital, junior doctor usually would have a look at ECS. They might print it out, they might write some stuff down in the case note, or maybe on a dedicated medicines reconciliation form. They'd write it all down again on the drug cardex, the drug chart, and then at discharge, they would manually type all that medicines information back into another system, TrackCare, which is where we used to produce our IDL documents. So obviously there's a lot of duplication of effort there, just looking at that picture. So this is roughly where we are now with the Orion system. We still have the GP systems feeding into ECS, but now we can pull that medicines information electronically into Portal's medicines reconciliation function, and that releases a bit of time for the doctors to think about the medicines information they're looking at. They still have to write the cardex out by hand, and that'll be true until we implement electronic prescribing. and we're just about to send out an invitation to tender for that, so it won't be too long. But at discharge, the medicines that were reconciled at admission feed in and become the starting point for the discharge medicines. So the doctor only has, or other prescriber, only has to update the system with what's changed while the patient's been in hospital, rather than having to enter all of the medicines from scratch. When we do implement electronic prescribing, it will fill in the right-hand bit of the picture. We'll actually take the medicines information from MedsRec electronically into HEPMA. That will become the starting point for the drug chart. And at the end of the hospital stay, the drug chart, as it now is, will feed back out and become the starting point for the discharge meds. So that will further reduce the need for transcription. Now, obviously, those diagrams are a bit simplified. That's quite a high-level picture of the process. This is a little bit more detailed, and this shows you some of the different groups of staff that are involved in the process: doctors and other prescribers, clinical pharmacists, pharmacy technicians, and ward nurses. And it also gives you an idea of some of the different steps that happen at different points in the patient's stay. There's things that happen at admission, while the patient's in the ward, and then around the point of discharge. And then this zooms in further. This is a more kind of exact representation of all the individual steps in the process. And you can see this horizontal bit in the middle I've labelled happy path. That's the kind of, if nothing weird happens, that's the kind of simple A, B, C, D all the way through to discharge. That path might be happy, but it's not very common. It's really, really common that all sorts of deviations and exceptions and loops happen in real life. And I'll talk a little bit about how we coped with that later on. Okay, so where have we got to? So Game of Thrones is full of blood and guts and scary monsters and tyrants vying for supremacy. So it's nothing like implementing clinical change in hospitals, obviously. Last year when I spoke to you, I claimed we were going to complete our pilot in 2 hospital sites, review and make a go, no-go decision, roll the system out across the board, and then review feedback from users and plan ongoing improvements to the system. And we did, mostly, and I'll talk about that too. So this first picture shows you, I think that's months along the bottom, and the different sites that we went live at. And you can see this is kind of our pilot phase up to here, and then from kind of March, we've had quite a rapid rollout across almost all of the acute hospitals in the board, and I'll expand on that a little in a moment. But as we stand at the moment, we have about 260 wards live with the system. And in terms of the number of ideal pathways that have been done on the system, when I pulled the data for this graph a couple of weeks ago, we were sitting at 77,000 patients who'd been admitted and discharged and had their medicines and other clinical information recorded on the Orion system. This data is from yesterday, so it's a little bit more up to date. So we've now had 85,000 pathways completed, just over 250,000 medicines reviews done on the system, and not too far off 3 million individual medicines recorded since March. So it's quite encouraging to see that it is working at this kind of scale. We do have some unfinished business. We have one small acute hospital that isn't live yet, and I'll talk about why that is in a minute. And then after that, we'll move on to roll the system out to mental health inpatients. We have about 1,000 mental health beds in the board, and that will be our next phase of implementation. Okay, how did we go about doing this? What approach did we use? First, we had a cunning plan, which was roughly, we spent quite a lot of time designing and building the system, and as a number of folk spoke about this morning, we worked very closely with as many clinicians as we could get our hands on. I will say I absolutely agree that engaging early and often with clinicians is the right thing to do. I'll also say it doesn't prevent people later saying this isn't what we wanted. So it's essential, but it's not sufficient. We then moved on to run the system in 2 pilot sites. Our first was a specialist cancer hospital, quite small, 9 wards, but at the very complex end of the spectrum in terms of prescribing. So these are patients who are in and out of hospital very frequently. They are often on a lot of medicines, very complex treatment regimes, and medicines that have a lot of side effects and interactions. And that was a good opportunity for us to test the system's ability to cope with that complexity while still being a reasonably manageable scale. We then moved on to pilot in our second site, which was one of our district general hospitals, a much larger site and a lot more representative of a normal acute receiving hospital. And once we were happy that the pilot had been successful, we proceeded to roll out quite rapidly across the board, roughly 15 new wards going live each week. We looked for super users in each ward, from doctors and from nurses and from pharmacy staff. And we did orientation and training sessions for the super users before each site went live. But what we didn't do was classroom-based training for end users. And that was very deliberate. Instead, we had a team of facilitators on the floor, in clinical areas, on the wards, providing training and support in real life, in real time, for real patients. And the way we trained users was essentially grab them and sit down with them as they go through their first couple of admissions, their first couple of discharges. We also had a bat phone. So although we were physically out on the site and we actually had high-vis vests on, which sounds ridiculous, but within about half an hour, we realised it really encourages people to ask for help. It did mean we occasionally got asked to fix the lifts, but that was a price worth paying. We also had a hotline, so between 8 in the morning and 6 in the evening, Monday to Friday, any of the wards that were using the system could phone the hotline and we would get someone out to them as quickly as possible. And in practice, that was usually within 5 or 10 minutes. And you can imagine that that gives users a real feeling that they are being supported, that there's help there if they need it, which went a long way to getting confidence amongst our users. We did run some specific sessions for night shift staff and for weekend staff. And as we progressed with the rollout, as we finished at a site, that would transition to our sort of normal operational support, and we would move on to the next site. We also had some more traditional training materials, printed guides, electronic guides, video clips, website, etc. Okay, I'd like to talk about some of the things we've learned over the last year. I'm going to start with the things that we think went well. That's my team, and I would say the most important factor in the success we've had, such as it is having a really good team of people. And I've reflected a little bit on what made them a good team, and there's a number of things. None of these will be particularly surprising, but I think they're worth talking about. Communication skills are absolutely paramount. We've got a team of folk here who are in clinical areas dealing with doctors and nurses and pharmacy staff of all seniorities in very pressured situations, trying to encourage them to sit down and learn a new computer system when probably what they'd rather do is look after patients. So that's really challenging, and the ability to communicate clearly and effectively with people at any level of seniority from any profession is absolutely essential. Flexibility is also very important. We didn't have scheduled times to be there. We were there all the time. And that meant that if we said, have you got 10 minutes to sit down and see this new system? If the answer was, no, I don't, you'll need to come back later, then we had to come back later. And sometimes it would be, well, I'm not finished this surgical list until 12:30. Can you be there on the dot, please? And I'll give you 10 minutes. So we had to be very, very flexible. And we also need to be very patient. It wasn't unheard of to be asked to come back to the same ward 4 or 5 or 6 times in the space of a day. And that can be very frustrating, but it's very important to appreciate that the reason for that, usually, and I'll come on to that in a minute, is because there are other clinical priorities that take precedence. But the flip side to that is my team also had to be appropriately assertive, because eventually, if a ward keeps asking you to come back, maybe it's not clinical priorities, maybe they don't want to change the way they work and learn the new system. So we had to find a balance between offering help, being sensitive, but also saying, look, we're only here for another couple of weeks before we move on. Now's the time for you to learn this system. Please find the time to sit down with us. And that was a tricky balance to get right. Mutual support was really important. This was a long and very intense programme of work. And most of the people on the team had no previous health background, no clinical background, but we were putting them in real clinical areas, sometimes in quite distressing situations. And in particular, one of the last sites we went live at, which was our specialist children's hospital, you're inevitably exposed to really distressing situations for patients and for families. And it was really important that the team could pull together as a team and support each other through that experience, as well as supporting the users. And the last thing I think is very important about the team is energy. As I say, this was a long and difficult 12 months, and the ability to every day to turn up at work with that energy, with that enthusiasm, with that positivity that you really need to bring the users with you and get them to change the way they work. That's absolutely essential. We took a bit of a gamble with our approach to support and training. Those of you who were here last year, I said at that time, we think this will work, but we didn't know because we hadn't tried it before. It did work. So we had extremely positive feedback from the clinical staff in the clinical areas that this way of providing training and support works much better for them than booking classroom sessions, which half the time they have to cancel and can't attend. And if you do them too far in advance of go live, by the time they go live, they've forgotten what they saw in the classroom anyway. So hugely positive feedback that approach, that proactive, on the floor approach worked really, really well. Also fed back that the short, visual, simple training aids worked really well. Long guides, not so much, because no one has time to read them. Users like to feel they are supported, and they told us that the approach we used made them feel that way, which was fantastic to hear. And they also like to feel that they're being listened to. Throughout the project, we have listened to what users have told us they would like to improve, and we've improved as much of that as we can as we've gone. So the system that we implemented at the last sites was significantly better than the first sites. But also a lesson learned for me, and we'll take this into future work. That approach to training and support did work for us, but I think next time we would back that up with formal e-learning, with formal mandatory assessment around that e-learning if we can, and if possible, link that to actually giving folk access to the live system. Because although it didn't happen often, we did get people saying, well, I never got any training on this system. Sometimes that was true. Sometimes they'd been too busy or we'd missed them. Sometimes they'd had training from 6 or 7 different facilitators, but nonetheless, I think backing up the proactive approach with something more formal would probably be the optimum. We also got some positive feedback about the system. It's a more robust process than what we used to do. It handles last-minute changes to medicines, which happen all the time. It handles those better than the way we used to work. It saves time at discharge, provided you do MedsRec at admission. And that feeling that the system was continuing to improve over time did build confidence for our users. And we've also got some early evidence that suggests we're getting some of the quality improvements we were looking for. The data we're starting to get out of the system now is showing us wards that are doing really well with MedsRec, high quality, high uptake. And some of those are really busy wards, so it's not just the quiet ones that manage. And it's also showing it's areas that are struggling more. And then clearly it gives us the opportunity to look at how the wards that are doing well, what are they doing, and how do we spread that approach to the areas that need help. The information on the ideal document is better. In particular, one of the things GPs were most concerned about before we started was discontinued medicines, medicines that the hospital clinicians stop. Because what used to happen is often they simply wouldn't be on the ideal. So the GP had no idea whether it had been stopped on purpose or missed or forgotten about. Because of the way this system works, if you stop a medicine, you have to actually tell the system you're doing that, and therefore that can automatically be included on the document. And finally, not something we expected, but we found that the quality of documentation of follow-up arrangements, for whatever reason, was better with the new system than previously. And just to summarise those positives, I think you sometimes hear people saying, well, eHealth can't drive clinical change. We're just there to do the technology. Clinical change belongs to somebody else. I don't think that's right. I think eHealth has to be part of driving clinical change. But achieving sustainable change is really difficult. and it requires ongoing senior clinical leadership and ownership. And a leader is something you do, it's not something you are. So we need our senior clinicians to think of the process as important and to monitor what their teams are doing and to deal with, to take action where those processes are not being done correctly or to a high degree of quality. Okay, I also want to cover some of the things that we'd probably do differently in the future. The first real challenge we came up against was around performance and reliability. So in our board, more and more people are using Clinical Portal, and they're using it to do more and more things. So Portal is, over time, working harder and harder, and we got to the point where the demands we were putting on the system outstripped its capacity. So we had to pause the rollout, and we've had to do a number of technical upgrades to the system to give it that additional capacity to cope with what we're now asking it to do. And that's why our final acute hospital isn't actually live yet. We literally had to pause and do this work before we could continue. Okay, next challenge is relating to how you join up different bits of Orion's portal functions. So the key bits for this project are the medicines management module and the healthcare pathways module. And our solution overlaps both of those, and here be dragons. So what we found is that, first of all, the real life process for IDL is complicated or complex, or both. MedsMan and healthcare pathways do have rich functionality, but within Portal, they're more or less distinct, they're more or less independent of each other. But to make this solution work, we required a lot of pretty significant and quite complex bespoke development to pull together those two components. And it's really difficult to account for all the possible exceptions and edge cases and deviations and patient flows that happen in real life. So throughout the rollout, and particularly as we get more and more patients going through the pathway, we find new obscure scenarios that we've not seen before that aren't quite handled, and we need to continue to update the system to cope with those. Training and support wasn't all positive. The super user model is brilliant when it works. We often found it very difficult to get meaningful super users, particularly from doctors and nurses. Pharmacy engaged really well and did make super users available and took a very active role. We did struggle with a lot of areas to do the same for doctors and nurses. And we also found that teaching the basics of the system is dead easy because it is very straightforward. But where the challenge is training and educating users to cope with all the exceptions, all the variation, and that's much harder. And we also had some negative feedback from users. It doesn't save time at discharge if you don't do MedsRec at admission. So if you save up all the work to the last minute, it's not going to be any quicker than the way we worked before. Some of the complex bits of the system are a bit clunky, a bit tricky to use. And in high turnover areas where you've got little or no work on the actual medication, this system can actually take longer than what we used to do before. In the main, it is quicker, but in specific areas like day surgery units, it's slower. And we're working with some of our DSUs to find a kind of accelerated path through the process that will work for them, or work better for them. And finally, the new system is a tool that can help clinical staff do a better job, but it's not going to do the job for them. And the clinical practice issues that we continue to find challenging, getting admission MedsRec done early and done well, getting coded diagnoses recorded well and often, getting the discharge meds done right, and also making sure that the IDL document has enough detail about the supply of medicines as well as what medicines are prescribed. And these have all been ongoing challenges. So what's next for us? First, we want to complete the rollout, and that means our final very small acute hospital, and then, as I say, mental health inpatients. Mental health's interesting. It has a comparatively low volume of admissions and discharges, but that actually makes this harder, not easier, because it takes longer for staff to have done enough to really get familiar with the system. And that means we need to be on site for a longer period. And also, we have quite a lot of mental health sites spread out across quite a large area, and that is challenging when you're trying to have people physically on the wards. We'll continue to enhance and improve the system. We've pulled together a very long list of potential enhancements from what our users have told us, and we've assessed those clinically and from an effort perspective. And we'll kind of work with Orion on an ongoing agile sort of basis to try and work through as many of those as we can and gradually improve the system further. And then we're going to procure and implement full electronic prescribing. It's the next big bit of the jigsaw for our electronic patient record. And our vision is that medicines reconciliation at admission and the IDL at discharge bookend the HEPMA process that happens while the patient's on the ward. There are some challenges there in terms of the technical joining up between the different systems and also in achieving a consistent clinical process across the whole board. But the learning from the last year, the learning from the MedsRec IDL project will directly inform how we go about implementing HEPMA at a similar scale and a similar pace. So, a few conclusions. The actual process is complex. The solution isn't perfect. We've got a lot of lessons learned from the last year, which will help us in the future. And it's absolutely essential to keep listening to your users and then do something about what they tell you. But Clinical Portal definitely can support a better way of doing MedsRec and IDLs. The different approach to training and support that we took worked really well for us. And it is possible to implement technology-enabled change at scale and at pace if you resource it. That's all I want to say, and I'd be really happy to answer any questions. Thank you.